Okay, so good afternoon, everybody. Good evening. It's the first one that we've done, and it's getting dark. The nights are definitely drawing in. So another 5K Your Way Facebook Live. I'm really delighted to have with us today Sarah Russell, who has been a big supporter of ours, and I've been a big fan ever since she reached out to me a couple of years ago when we were just kind of dreaming about 5K Your Way. I think maybe we just started, and Sarah was starting to write this amazing book, the Bowel Cancer Recovery Toolkit. So Sarah's a clinical exercise specialist. She's a clinical Pilates teacher, and she's a cancer rehab specialist. She's lived with a stoma since 2010. She's the author of this book, as I told you. She's also a runner. She's run 33 marathons. I believe she used to be, many years ago, a GB rower. And she's run some super cool ultra endurance events, including the Himalayan 100 miler over 5 days, and the Trans Rockies. So I'm quite jealous about those. But we're going to talk today a little bit about bowel cancer surgery, stomas, and getting back into exercise activity after bowel cancer, abdominal surgery, but particularly bowel cancer surgery. And I think what we'd both love to do during this session is provide some confidence to anybody who is about to have surgery in their abdomen, that firstly, you can live a completely normal life after it. And secondly, some tips and some practical ideas to help you get back into activity after surgery. So Sarah is an expert. I mean, I'll let you tell everybody about what you do. But can you just tell us a little bit about how you've ended up where you are?
Sure. What, with the stoma or sort of professionally?
Well, professionally, how you got to where we're having this conversation now, okay. And your this book.
Very long story cut short. I did a sport and exercise science degree and then a master's degree, worked in cardiac rehab, was really interested in working in special populations, so a lot in kind of rehab, injury rehab, those kind of areas. I was a runner, triathlete, doing GB age group triathlon, and then 2010 I had this kind of really weird abdominal pain, rushed into hospital, turned out I had peritonitis and had a perforated colon. Not actually from bowel cancer, but from a condition called diverticulitis, which I didn't even know what it was, but I never even knew what stoma was at that point. But even though I had sort of at that point 20 years of experience working in the fitness industry and a master's degree, I still didn't know how to rehabilitate myself after major abdominal surgery. And so I started sort of looking around and thinking, you know, what is there out there? What information is there out there? And couldn't really find any. So I then had this really horrendous journey of sort of 2.5 years. I had 5 major abdominal surgeries, 3 different stomas, and had to kind of rehabilitate every single time. So by the time I got through all of that, I kind of went, there's a massive gap here, and someone needs to start educating clinicians, nurses, and really putting some advice and support out there on how to actually go through that rehab process, because it's incredibly important. So I started kind of doing some research, working with a company called Convatec, who are a medical devices company. They manufacture stoma bags. And we did some really great research, surveyed thousands of patients around the UK, and kind of really found some kind of worrying evidence that nobody was getting advice about exercise, nobody was getting advice about abdominal exercises, and people's activity levels were becoming much lower once they had their stoma surgery. So I thought, right, we've really got to change this. So we produced some sort of really good resources for Convatec, and then I started writing the book. And that's kind of where it went. And then after my surgery, so 2012 by this point, I got back into running. By that point, I'd done about 10 marathons, and I was training for an Ironman. And then by the time I'd gone through my surgeries, I was like, right, what races can I do? What can be my first sort of comeback race? So I chose the Jungfrau Marathon in Switzerland, and that was my first race after after all of that. So shuffled slowly around that, but it was an amazing day, and just kind of gone in a slightly different direction with my own training and events, really. So yeah, that's kind of where I'm at. And I'm hugely passionate about exercise, when you have a stoma, and exercise when you're going through bowel cancer treatment, and also how to do it safely and appropriately, and just empowering people with knowledge and skills to feel confident to be able to move without being scared of damaging themselves.
So I think for a lot of people, there's still a huge amount of unknown about what a stoma is, different kinds of stomas, how stomas work. Can you just tell us, so obviously I'm sure a lot of listeners what a stoma is.
I just missed that last bit, but obviously step in from a medical perspective if I'm not saying quite the right thing. But so a stoma is basically an artificial opening anywhere in the body, but when we're talking about stomas in this context, we're talking about on the abdomen. And for majority of people will have a stoma from the bowel. Some people have a stoma from their bladder as well, which is known as a urostomy. But stomas for the bowel, which is probably what we'll be talking about more so here, are colostomies or ileostomies. So the bowel, or an opening from the bladder, is brought to the surface of the abdomen, and you create like sort of artificial holes that basically becomes your kind of anus, if you like, and that's where your waste comes out. So everything from kind of below that point is either removed or bypassed, and then your waste comes out of this hole on your abdomen, which is the craziest thought in the world, but actually it's fascinating, and whoever came up with that is like amazing, because it saves lives. And when you first hear that you have to have this done, you think, what is that? That sounds horrific. And actually the reality is that it's really not that bad once you get used to it and you live with it. And I kind of get to the point now where I almost forget I've got one. So I'll go to do talks and I'll be saying all the things I do, and then people go, but you've got a stoma. I'm like, oh yeah, I do, because I've forgotten. And so, you know, when you get to that point, when you forget about it, you know you've kind of come through the other side. So the stoma is brought to the abdominal wall, and you have to wear an appliance or a bag over the top of it, because it's effectively, you don't have control over it like you would normally over your bowel or your bladder. So you have to wear a bag over the top to kind of collect what comes out of it. So it kind of looks like that. That's a drainable ileostomy bag. And you stick that over the top, and waste just comes out of your bowel or your bladder, and you empty it into the toilet, or you change the bag depending on the type of stoma you have. So if we're talking about bowel cancer, typically you would either have a colostomy or an ileostomy. Now, a colostomy is brought out of the colon, so we think about the large bowel, and an ileostomy is basically the terminal ileum, so the end of the small bowel, and that's the sort of slight difference between them. From what my understanding is of talking to colorectal surgeons, a lot of people with bowel cancer will have an ileostomy for a short period of time whilst they're having treatment, and then they have it reversed. So they have this temporary stoma whilst everything has surgery done in it, and then it heals, they have the chemotherapy, and then the kind of almost the last thing that happens is that stoma then gets reversed back. Some people will have a permanent stoma like myself, and you have that then for the rest of your life. Now, you know, and of course the other type of stoma is a urostomy from the bladder. And I do know a guy actually who has a urostomy because he had bowel cancer. And then any gynecological cancers as well. Sometimes people will have to have stomas because of those, because they've spread into the bowel or the bladder. So, and some people have two actually. They'll have all their organs removed and have a bag for the bowel and a bag for the bladder. So lots of different types. It's not that straightforward.
So you've done, so that's a really helpful explanation. You've done a very good job of telling people that you can live a completely normal, active life, going around marathons with this bag on your tummy. I imagine when you're that, as someone who hasn't encountered a stoma before, lots of things might come to your mind. Perhaps people are going to stare at me, it's going to be really obvious, it's going to be visible under my clothes, what if it leaks? Can you just dispel some of those myths about stomas?
So I remember when I first came home from hospital, I Googled kind of, what can you do when you've got a stoma? And I'd been quite, a GB age group triathlete, and I honestly thought that I might sort of end up having to go to the Paralympics or something like that. I was that naive that I really thought it would limit me that much. And looking back, I'm not sure where that came from, as I didn't know anyone who had a stoma at that point. Now, of course, it's like buses. I know millions of people with stomas. I work with them, but back then I didn't really know. So I don't know where that message of disability came from. But that was my first kind of Google search, which actually was a bit strange. Anyway, I found this guy called Rob Hill, who had literally, like 2 weeks beforehand, climbed Mount Everest. So I thought, oh, right, well, if you can climb Mount Everest, you probably are going to get into the Paralympics, and that probably means you can go and run a marathon, because climbing Mount Everest is quite difficult. So I'm sure that you can go and do normal stuff. And that was literally all I needed to know, is that was, if that's the limit of what's in the limitations, then yeah. So for me, that then just dispelled all the myths and opened the doors. That's not to say that it wasn't easy to sort of adjust to it, because you do have leakage, and by that I mean the bag will kind of maybe come away a bit, or there'll be some feces that gets under the bag and comes out, or it comes off at night, and all those things are really difficult to deal with initially. You have to have a bit of a sense of humour about it though, because otherwise you'll just tie yourself into knots. So luckily my husband's really cool, my kids were really cool about it. They were kind of more curious about it than than anything else. And I just sort of really ended up just going, you just got to laugh and just deal with it and move on, because it is challenging to begin with. So the leakage side of things, what you do need to do though is experiment with as many different products as possible, because there are hundreds of different bags out there. And if you experience leakage, that's not normal, and you can find a better product and a better system that will work for you. So just keep experimenting and keep trying, and contact your stoma nurse, contact your the people that can help you, and just keep trying until you find something that works for you, because you will.
So I think that's a really important point. Don't settle for something that's not working perfectly. And just with the stoma nurse, should everybody who has a stoma, should everyone be given a nominated stoma nurse?
You will in hospital, you have a nominated stoma nurse, and it varies really around from hospital to hospital about how much contact you'll have with them post-surgery. Some people have an ongoing relationship with them, and some people kind of get discharged quite soon and they feel a little bit cut adrift. It kind of depends on the hospital and how much they've got on their caseload, and also on you as an individual. I was quite happy to be cut adrift because I kind of had figured it out for myself, and I just was able to, work it out. And
if someone is at home struggling for whatever reason, the stoma is not working, is leaking, they're getting skin rashes or whatever, and they don't know who to call, what would you recommend they do?
I mean, their first port of call would be the stoma nurse that cared for them, or the stoma nurse in their local hospital that they fall under. That would be kind of the person to try and reach out to. Failing that, Convatec, who I work with, they do have a nurse advisor line, and that's free of charge, so people can just call that and get some specific nurse support, and they're doing telehealth and video calls and stuff. So that's a really good place to go as well if you're really stuck and there's no one to help you. Or go to your GP, although from my experience GPs' knowledge is a little bit limited when it comes to stomas. So that's stoma nurse, or reach out to one of the companies who can help.
But don't be scared to ask. I mean, I think that's something I see, and in cancer in general, sometimes people are so scared to ask for help, and they sit at home and don't tell us that they've got problems. And always, when we find out 3 months later, we always just wish that they'd have the confidence to.
Yeah, I think there's an element as well, though, of certainly with stomas, is because you kind of fall into a level of acceptance as this is what's okay. So my skin's red, raw and sore, and I'm having leakage, but that's normal, and everyone must be experiencing that. And I mean, I certainly had that experience at the beginning, and I remember just thinking, oh, this is just how it's going to be. And the reality is it's not. If you've got really sore skin or you're having leakage, that is not normal. and to reach out and get some help. You know, and don't settle until you've got it sorted and you've got some help, because it's out there. You know, you might have to look a bit for it. You know, and the charities can probably help as well, the Ileostomy Association, the Colostomy Association, and, you know, other patients as well on forums are always a really good source of help, particularly when it comes to tips and tricks with stone bags.
Okay, so that's a really good tip. So let's talk about exercise. What can you do with the stoma?
Well, climb Mount Everest. So you don't have to go to Paralympics. So I know people now who compete at the highest level in sport, who run marathons, very fast times. There's a guy I know in America who's just run a 2:27 marathon with an ileostomy, had Crohn's disease or colitis, I think.
That's pretty quick for anyone who does marathon time.
Yeah. There's a triathlete in the UK called Michelle Wilcox, who is an age group world champion. She has an ileostomy.
I know Michelle.
I mean, not from cancer, they're from other conditions. But the message is really that there's nothing you can't do. That's not to say there are challenges, and the challenge is really when you get to it's sort of that level, really it's about the sort of biomechanical changes of your body in the way that your core muscles are functioning, because you've got this kind of permanent hole, if you like, in your abdominal wall. But also actually, particularly for people with ileostomies, and this really applies a lot to people that are having chemotherapy who've got ileostomies as well, is hydration is a really big issue. Because if you think about when you've got an ileostomy, that's off the small bowel. So the colon would normally be absorbing fluid from your feces. With that then diverted or removed, you don't have that anymore. So it's a little bit like having diarrhea 24 hours a day.
So just for anyone who doesn't know, you've got your swallowing tube, your esophagus, it goes into the stomach, where a lot of the food's absorbed, then it goes into the small bowel, and then it goes into the large bowel, and then it comes out of the rectum and anus. Just a very, very basic. So small bowel, obviously there's been a lot less bowel to absorb stuff, absorb what's going through.
We need like a little plastic model.
Yeah.
So with an ileostomy, you don't have that colon, that large bowel, which is absorbing the fluid. It's just the small bowel that's there. So what comes out of the stoma is very, very liquid and very watery, and can be, and you can end up quite dehydrated. So I kind of bang on about hydration a lot, because I think that can often be a real barrier for people to be active, because if they're feeling fatigued, groggy, a bit dehydrated, they accept that that's a normal state of affairs, and it's not. You don't have to accept that. You have to then adjust your hydration strategy to really kind of get on top of it. So you can be active and you can live a normal life. You don't have to feel groggy with a headache all the time.
So you might need to increase your fluid intake, perhaps increase your electrolyte intake more than before you had your ileostomy. Yeah,
absolutely. So, and I often say to people not to drink plain water, to try and then increase electrolytes, as you were saying. So even just things like drinking diaryolite, so an oral rehydration solution is actually generally what I certainly use on a daily basis. So just to kind of keep well hydrated all the time, rather than kind of getting dehydrated and then trying to top back up, and you end up on this kind of roller coaster of hydration and dehydration. So, and certainly during exercise, long distance exercise in the heat, like we were in India and in Colorado, that was really challenging from an ileostomy perspective. So when I went to India, it was a 100-mile stage race over 5 days. So it was well split out, but it was at altitude and it was warm. And I've got quite a high output ileostomy. So that was a massive challenge, really, from trying to manage all of those things. So yeah, there was a lot of diaryolite being drunk that week.
So you're clearly like me. You like your extreme challenges, but for most people perhaps might go for a 2K run or a 5K walk or a 30-minute Zumba class. It's probably perhaps a bit less of a concern, and you could perhaps just think about a bit more fluid with some electrolytes before and after.
Yeah, I still think, I mean, there has been some research done which shows that the majority of people with an ileostomy are showing kind of clinical signs of dehydration all the time. So
Yeah.
I would still recommend Diarrhea to almost everybody with an ileostomy. It's like having diarrhea all the time. So you would, if you had that, you would replace that with electrolytes. So, and I think even people who just want to be generally active, who want to go out for a walk, if you're feeling grotty and groggy and headachy, those things are going to be more difficult for you to do because you're just not going to feel well. And that is often just because you're dehydrated. So I've written some resources and stuff, which we've published on the Convatec website, and there's some nice stuff on there, just kind of explaining that. But yeah, I think even if you don't want to do extreme stupid things, I think still hydration is super, super important, just on a day-to-day basis, just to feel well.
And what about kind of heavy lifting? So you might imagine you've got a hole in your abdominal wall, heavy lifting and straining, and talk us through that. Is that how can you get around that?
So one of the key messages that almost everybody with an ileostomy is told is not to lift heavy things. So I remember a nurse saying to me, so when you get home, you mustn't lift anything heavy. So I was like, oh, what, like a wardrobe or some drawers or something? Because to me that was heavy, right? So what she meant actually was a kettle.
The classic.
So I thought, and I was like, hang on a minute, a kettle's not heavy. But that is the reality, is once you've had abdominal surgery, you realise that actually a kettle is quite heavy. However, from a clinical Pilates perspective, rehabilitating those deep inner core muscles is actually the most important thing to do. So move forwards. Yes, you can lift heavy things. Yes, you can weight train. I weight train. I do kettlebells. I lift kids, dogs, whatever. I do lift heavy things. I do lift wardrobes and chests of drawers and kettles. But you don't go from surgery to that. There's a real kind of rehabilitation process where you need to really work on those internal core muscles to get the diaphragm, those transverse abdominals and the pelvic floor all working together in synergy. So they'll kind of create like scaffolding on the inside for your stoma. There's a lot of fear around peristomal hernia. So something like, so a hernia around the stoma. So it's just where additional loops of bowel kind of start to follow through and sit underneath the skin, behind sort of in front of the abdominal wall. So you've got these loops of bowel that are just protruded through, and a hernia can just look like a bulge on the abdomen. They can be unsightly. People can feel really self-conscious of them. Sometimes they're really small. People don't know about them. They're not even aware they've got one. And at the sort of worst end of the spectrum, they can sort of strangulate and twist and cause really big problems. So there's a lot of fear around peristomal hernias, and a lot of the surgeons and nurses will sort of say, well, don't do this in case you get a hernia. So a lot of people with stomas are really scared and worried about developing a hernia or making one worse. And I'm really passionate about kind of what we call reducing the risk of developing a hernia. So doing as much as you can as an individual to kind of reduce that risk. I'm not sure we can ever prevent them. Something like 70% of people with stomas will go on to get one of some description. I've got a really small one. It's not getting any bigger. I do Pilates and teach Pilates, and that's really, really helping keeping it under control. So I think that's a really important message, is you can lift heavy stuff, but only once you've kind of rehabilitated properly.
So in the NHS, we're very good at doing, well, we're quite good at doing pretty good surgery. I think most people with cancer get the big stuff done pretty well. But like you say, the standard advice, and I saw a patient yesterday actually who has just had some big abdominal surgery, and he asked me for some advice about how he could get back into it. He wants to play rugby again. And he said the surgeons had told him he couldn't do anything for 2 months, and I actually didn't know how to answer that. But what struck me was he had been given no guidance. He was 5.5 weeks post his surgery, and he'd been given no guidance from physios as to how he might be able to build up his strength and his core so that he could get back into exercise. So he'd been given the standard advice, just like you, don't lift anything heavier than a kettle for 2 months. And he's 18 and he wants to go and play rugby. So
and sadly is what we hear over and over and over again. So we did our survey back in 2016, which we published the research in the British Journal of Nursing, and what we found there was around, I think it's about 87% of patients had never been given any advice. Now it's kind of a bit of a tricky one though, because doctors, surgeons and oncologists aren't really given training on abdominal rehabilitation. Neither are stoma nurses. And actually, it's something that physiotherapists don't get either. So physiotherapists are great at musculoskeletal stuff, but they're never trained in abdominal rehab. So it's this kind of like great big bit that's falling through the net that nobody is getting. So the type of stuff you would do and you should do is really kind of like the similar exercises to postnatal rehab. So just kind of reconnecting the diaphragm, starting with some sort of diaphragmatic breathing exercises, connecting those muscles, pelvic tilts when you're lying on your back, those sorts of really early phase stuff to get these muscles working and functioning. And you don't wait till 2 months post-op. You start, the Association of Stoma Care Nurses have actually published guidelines, and their clinical guidelines state that you can start to do those sorts of abdominal exercises 3 to 4 days post-op, if you're well enough. And you then progress from there in like little nibbly layers until you just feel like you've got control of those deep internal core muscles. Of course, you wouldn't go straight to a plank or a sit-up. There's a really progressive, gentle phase.
So what I really like in the book, and I actually found it really interesting from a medical perspective, is you have different chapters. So you have, and you talk about a progression that you could use to strengthen your pelvic floor and to strengthen your core to give you that foundation. So can you just describe what you mean by pelvic floor and core, and why strengthening that? Because it's kind of stuff that probably feels quite dull to most people. You don't get endorphins. It's not like high energy, high excitement. Just talk through what that is and why that's important.
So I suppose when we've had any kind of trauma to any of the muscles in the abdominal pelvic region, it makes intuitive sense to rehabilitate them in some way, to strengthen them, to get them kind of working again. There's been trauma to them. So the muscles are kind of switch off, and we need to get the brain reconnecting with those muscles again, so that then you know what it feels like when you can kind of get that drawing in of the deep muscles. So when we talk about the inner core muscles, we're talking about the diaphragm, the transverse abdominis is like a kind of deep girdle type muscle which wraps around, and the pelvic floor muscles. The pelvic floor muscles are like a sort of sling at the bottom of your pelvis, between your sit bones, your coccyx and your pubic bone, and it's like a bit of a sling, and they hold everything up. Now, depending on the type of surgery you've had, the extent of the surgery you've had, all of those muscles can be compromised in some sort of way. So, and what will happen is post-surgery, you're in pain, you start with kind of guarding, your posture changes, you'll be moving in a very different way. So we need to get those muscles, that deep internal core, working for us again correctly. And so we start with simple breathing exercises, using the diaphragm, using the ribs, just starting to get that moving. It's not, as you say, it's not sexy, it's not exciting, but I talk about it like you imagine your house has been knocked down. You've got to start by rebuilding at the foundation. So you build the foundations first, then you put the first floor on, then you put the second floor on, the roof, and then the chimney. And the chimney might be something like a plank, so that's the kind of layering process that we get to. So those deep internal core muscles, and this is where clinical Pilates comes in, because these are the sorts of exercises you would do. So sort of postnatal clinical Pilates, very early stuff that people might be familiar with if they've ever had back pain and back problems, those sorts of things. Knee rolls, pelvic tilts on the bed, really, really simple, gentle stuff, but it gets those muscles functioning, talking to each other. Then we can start layering up and building and working on the more fancy muscles that sit around the sort of outer core, like the obliques and that kind of rectus six-pack muscle down the front. Does that make sense?
One of the key things I would take from that is that you can start that really early. So yes, you need to talk to your surgeons and whoever is looking after you in the hospital, but that's not something that you need to wait 8 weeks down the line. You can start that.
Absolutely not. Absolutely not. And many patients will, if they can, do it pre-operatively as well. So if they've been given a diagnosis and they've got a couple of weeks to wait until their surgery, or they're having some chemo or some radiotherapy, that's the ideal time to start. If you can, you feel able to, because you can just train those movements and you know what they're going to feel like, so you know how to do them post-surgery when you might be feeling in pain, your posture might have changed a little bit.
And your book, we have no vested interest in selling your book, but it really does have, we're not getting commission or anything, but it really does have a really good guide and a structure that you could follow if you weren't getting any formal advice from anyone. Is there anywhere else? Are there any videos, any good resources that people could go to if they were about to have surgery or have just had surgery?
I mean, both the sort of Colostomy and Ileostomy Association charities have got some nice resources. The Colostomy Association have got a nice booklet about sort of active ostomates, people just, with different types of stomas and the sorts of return to activity in sport. I wrote a program called Me Plus Recovery, which is this for Convatec, and that's free of charge for anybody with stoma. So again, this has kind of all the different sort of exercises in it that you can do at home, and that's free of charge, and they'll send it out to you. And that's like a 3-phase program. So it's similar exercises to the book. But one of the cool things, sorry, go on.
No, I was going to say we can probably put those links on this page and when we upload the video as well.
Yeah, and there's videos. So I've created videos for each one of those exercises as well. So they're things that people can start in hospital 3 to 4 days post-surgery as per the clinical guidelines, and then they can progress once they get back home. If you've had your stoma surgery months ago and you've never done any of this, then you still start with those really early foundation phase exercises. A lot of people skip them because they think they're a bit lame, but actually it's really important to retrain those deep inner muscles to make sure you're connecting correctly. And it's kind of clinical Pilates speak, but it's about that deep internal core, like a corset muscle, like imagine it like being scaffolding or an internal support garment. So yeah, and then the other thing which I'm literally just about to launch is an online Pilates sort of Zoom classes for anybody with stomas. So and they'll be open to anybody anywhere in the world. So I'm going to start teaching those in about 3 weeks' time and launching that website.
So we'll link to your. I know you do one-to-one cancer rehab instruction for anyone.
Yeah, I do. Yeah, so I've taken everything online and I'm doing one-to-one cancer rehab. Or stoma rehab or anything like that. So Georgie, I'm not sure if you're listening, but I can't find a link. So if there are any questions that have come through live, could you WhatsApp me? Really not very technological. So things that I would think about, swimming. Can you swim with a stoma? Yeah, absolutely. So I swim with a tri club now, and I sort of just recently joined this tri club, having kind of starting, I'll get back into triathlon. And I go swimming and not one of them knows I've got a stoma. Not that I hide it because I've pretty much forgotten it's there, but to make the point that I go in a normal swimming costume, I do a warm up under the side of the pool, I do a normal, set of swim training, and no one knows it's there. So yes, you absolutely can swim. The big thing is most people just be frightened of the bag leaking or coming off, and that's not something you'd want to happen in the swimming pool. Mm-hmm. So you need to be kind of really confident with the bag you're using and know that you've got a secure seal and you're confident with it. You can get like these little extender strips which go around the base plate to help sort of keep it stuck in place, which give you a little bit more confidence, and that can be quite good as well. But you just need a normal swimsuit. You don't need anything kind of fancy.
And what about, say I was running a marathon, I was doing a 6-hour bike ride. how easy is it am I going to need to empty the bag? How easy is it to empty the bag?
So it would depend on whether you've got an ileostomy or a colostomy. And when you have a colostomy, what comes out of it is just like normal stool. So for most people. So, and that might just be once or twice a day. So if you're lucky and you're eating and you get used to when it's going to start to be active, you could probably time your bike ride or time your fueling around that. So you wouldn't need to worry. If you have an ileostomy, then that ileostomy is working all the time, 24 hours a day. Everybody's pattern will be very, very different. So I generally need to find somewhere to stop and empty. If I've gone out on a 5 or 6 hour bike ride, I will have to find somewhere to empty. But again, a lot depends on the individual. Some people will have much faster transit time, other people won't. So it's really about finding what works for you. Things like, I find taking Imodium before a ride really works well. A lot of people with ileostomies are prescribed Imodium or loperamide just to help slow down absorption or slow down the output, which improves absorption. And that's a really good tip because then you don't get as dehydrated.
That's really helpful, thank you. So we have got some comments. Thank you, Georgie, for sending them through. So Jenny has written, as a GP, I see a lot of problem with pelvic floors, including my own, both pre and post abdominal and gynae surgery. How can we work on more education around this?
I think there's some resources out there. I think there is a really big piece of work to be done about not normalizing it. So you see a lot of adverts on TV talking about pelvic floor leakage and it's normal to wear a pad or pants and that's great. And actually it's not, that's not normal and we need to seek help. So seek help from a women's health physiotherapist. If it's a gynae issue, if it's a pelvic floor issue and it's more bowel incontinence, you can do something about that. So it's really important to ask your GP for help, to get some resources. There are some resources online, there's some apps and there's some education happening. So there's some apps like the Squeezy app, which is an NHS physiotherapy app. And it just teaches you to, it's called Squeezy.
Mm-hmm. We'll have to get a link to that as well.
There's the male, as it sounds, male Squeezy, and it's around just teaching you to do your pelvic floor exercises. And there's a male version and a female version. But it's not just about the pelvic floor, it's about the way that the core works in synergy together. So everything has to work together. So you have to be breathing correctly. Those transverse abdominis muscles have to be working correctly, and the pelvic floor. It all works together in synergy. Those muscles are not separate things, and you don't just work the pelvic floor, everything has to work together. So as someone who teaches clinical Pilates, that's where I think it really is. It's about for men and for women. And I think it's about not accepting the issues you've got and looking for help and trying to get as much support as you can. And my feeling, and we're doing some research, we're doing a clinical trial at the moment called HALT, the Hernia Active Living Trial. And it's with Professor Jill Hubbard at the University of the Highlands. Mm-hmm. And we're looking at whether clinical Pilates can influence somebody that already has a parastomal hernia, and it can either change their hernia, stabilize it in some way, or make it smaller. And I'm very passionate about that as an approach to anybody with any kind of pelvic floor dysfunction or any incontinence issues or parastomal hernias.
And I think, again, we said it before, don't settle. Like if something is not right, never, ever, ever just sit at home and think this is as good as it's going to get, because there will almost always be help out there if you ask for it. So thanks Jenny. Jenny said the gynae physios can be quite helpful. Maybe they need to get involved with bowel patients. Gwyneth has said the adhesive collar on a stoma bag looks quite large. Is that uncomfortable when flexing and twisting?
So it's sort of this, I mean, that looks big on the camera, right? So when it's on the body, it's kind of like here. I'll be absolutely honest, when I'm teaching Pilates, I forget it's there. I can't feel it at all. Now, whether that's because I've had it for 10 years and I'm just used to it, but it's kind of soft. So there's a softness to it. But yeah, I honestly forget it's there and I don't feel it at all. I lie on my stomach. I do kind of exercises where I'm putting all my weight onto my abdomen, lifting up my arms and legs, I forget it's there, and I can twist and bend and do roll downs and forget it's there. So hopefully not.
Right, that's what you want to know. Shireen has said, I think the discussion about lack of guidance around exercise is really interesting. I found the same after breast cancer surgery. People seem to be left to find their own way, often with a lot of uncertainty and worry. I wonder what we can do to change this. So I mean, that's a unifying theme, I think. And this is why we're doing these Q&As. We're trying to do our little bit. Sophie has said, can you plug the stoma whilst you swim, or is that not a thing?
Can you what, sorry?
Can you plug the stoma whilst you swim, or is that not a thing?
So yes, if you have a colostomy. So with a colostomy, obviously that stool is much more formed and it might just operate once or twice a day. Some people that have a colostomy are quite fortunate in that they can irrigate the colon through the stoma, put a plug in and maybe get 24, 48 hours without anything coming out of it again. So that, like, you create a little plug. But with an ileostomy, you can't do that. The ileostomy flow just continuously comes through. So unfortunately not. But I personally find that using Imodium is kind of like, it gives me about an hour without anything coming out. So for me, that's my kind of trick. Other people use dietary changes, and they know what works for them when they eat at different times. But obviously you need to fuel yourself for exercise. So what you don't want to do is starve yourself because you don't want your stoma to work, because then you're not going to get the most out of your exercise because you've not eaten anything. So you've kind of got to get the fueling right. And with that comes this acceptance that you have to deal with this bag. So, yeah.
But you can deal with a bag. It takes time, like anything, but you can deal with it and do whatever you want to with it.
Yeah, yeah. But you just need to learn some tips and tricks. And just as a kind of, I think for me, what I found with a lot of people is having a stoma effectively makes you incontinent, because without that bag attached to your abdomen, you have no control over what's coming out of your body. Whereas, you've normally got a sphincter and you can control it to a certain extent. But with a stoma, you can't. You don't have a sphincter on your abdominal wall, so you don't have control. So there's a lot, I think for a lot of people, a feeling of a loss of control, and that can be really difficult to deal with. I think that underpins a lot of the issues.
And they don't smell, do they? Not at all.
They shouldn't do. I think historically maybe they did years ago, but the bags now are, there's so much research and development gone into them. There's so many technological aspects, there's filters in them, so nobody's ever told me I smell.
So slightly off topic, but Mike, who watches lots of these, hi Mike, I don't know if you're watching today, but he asked a different question. So with your cancer rehab instructor hat on, he's had lots of radiotherapy for prostate cancer, and he's got stiff and weakened hips. Are there any specific exercises or stretches he could do?
Oh gosh, that's a bit tricky. Not knowing him or seeing him. The first thing I'd ask is to just identify whether the stiff hips are actually a result of the radiotherapy and any kind of tissue damage, or whether it's more of a mechanical issue that's would have been there anyway, or there's some other issue. So I just get that checked maybe by a physiotherapist first, get some kind of assessment, and just really work on whatever advice they give you to work on strengthening the muscles around the hip and the pelvic floor. And that's never going to do harm, is to strengthen muscles. So I would go to strength before I go to stretching, but I'd get assessed really, just to make sure that you're unpicking exactly what's gone on there with the radiotherapy.
I think I'd agree as well. It's very hard to answer specific questions without.
If you could pop round tomorrow, I'll have a look at him.
We will always do our best to answer everything. Listen, Sarah, you've been absolutely amazing. I really think if you know someone who is about to have surgery or has just had this surgery, I really do think this book is useful. And I'm not saying this just because Sarah's on here. I've looked at it. I actually looked at it before it was published. I've looked at it again today, and it really is. It really is really good. It's very easy to understand, and it will give you a little bit of structure that the NHS won't. We might ask Sarah whether we can perhaps pirate some of the exercises to link up to this, but we'll definitely link into all the resources that you mentioned, and make sure that we can share those with you. Sarah, is there anything you want to add that we haven't talked about?
I think just that message of, you know, when I first was told I was going to have a stoma, I thought, wow, that is so weird. What is that even about? And that doesn't sound nice at all. But the reality is that actually, if you can get your head around it, it's really not that bad. And the more you can do to help yourself, and the more you can have a kind of problem-solving approach to it, it gives you a sense of control over it. And just don't accept feeling unwell, having a leaking bag, having a hernia, not being as active as you'd like. All those things are completely fixable. And it's, you know, you might have to do a bit of research, you might have to do a bit of reaching out, getting support, but don't accept, you know, any of those things, and just strive for wellness and happiness and well-being, rather than just kind of going, oh, this is it now, and I've got this stoma and it sucks. It doesn't have to be like that at all. You can really, you know, live your life the best you can. And there are a lot of worse things that could happen to you. I really do feel that. I think you've got to, you know, live with it, make the most of it, and try and be as active as you can. And if you're going through bowel cancer surgery and treatment, don't wait until it's all over before you start being active. Try and be active during treatment, because it will really help you from a sort of symptom control perspective, but also from a recurrence. And that's, you know, bowel cancer has got so much research around being active and reducing the risk of recurrence. So I'd say that just get active if you can.
And on that note, I think we're going to end with the final bit of your book, which is a little poem. We don't know who wrote it.
No, I don't know who wrote it. I'd love to find out.
Little end. The more I move, the better I feel. The better I feel, the more I heal. The more I heal, the more I can take. So let's get moving, for goodness sake. So on that note, thank you very much, Sarah. I've learned a lot. I'm sure anyone who's listening will have learned a lot. Sarah and I, we will leave Facebook. So thanks for listening, everyone, and goodbye.
Thank you. Bye.
Bye.